Hello, and welcome to another episode of the 9 to 5 Wellness Podcast. In this episode, we are pulling back the curtain on metabolic dysfunction and the GLP-1 era. We are going to be taking a deep dive today into how GLP-1 medications work, how they can improve our metabolic health beyond just the number on the scale, and what we need to know about these medications as users and practitioners. So, if you are a listener or viewer who is considering these drugs, or maybe you're already on them, or maybe you're someone um, who knows someone in their family or friends who is on them, and you are trying to just simply understand this shift in healthcare with the GLP-1 drugs, this episode is for you. And in order to understand all of this, I have a very, very special guest with me today. Our guest today is Dr. Pankaj Rajvanshi. He is a board certified physician in gastrointestinal disorders and obesity medicine and the founder of Stealth AI startup. He aims to empower patients with obesity care using GLP-1 medications and AI tools. And I can tell you, I met him at Obesity Medicine Association recently, and he's a wealth of knowledge. So you are in for a big treat with this interview. Welcome to the podcast, Dr. Rajvanshi.
Thank you, Aisha. Thank you for giving this platform. These medications or focus on health with weight reduction is exploding globally. And I think it's time to be talking about this openly, have people understand exactly what's going on in their body and where do we need to go with this. Thank you for the invitation. I'm looking forward to
Oh, you are welcome.
conversation.
I am so glad you could, find the time to join us today. And I agree that there is such a big shift happening right now with GLP-1 medications and the focus on metabolic health, which it should be. And the more we talk about it, the more we normalize it, the more people understand how they can get more help. So I am so glad that we are doing this as well. I want to start with the basics. What is metabolic dysfunction in simple terms? If a patient comes to you and they're like, Dr. Rajvanshi, I'm kind of like at a loss, like I'm not sure what, my primary care keeps saying that this is what I have, but what is it?
Yeah, I think we use a lot of big words when we talk to patients or write about these things: metabolic, dysregulation, regulation. What exactly is this? What is metabolism or what is dysregulation of metabolism? So think of it this way. So hundreds of years ago, we were out in the forests and hunting, and had this limited food supply, or we thought we had limited food supply, and our body was designed to gather and store and keep. We didn't know whether we'll get when we get our next meal. So so that's where we are coming from as originally evolving human beings. Take this analogy to, let's take it to your car. Okay, so I think that'll make it easier. So suppose you have a car that has this metal shell. Instead of being metal, it's flexible, plasticky stuff. Okay. Now you have a gas tank in which you fill the gas. So you're getting out there, you fill gas in your car and you drive away. Now, if your car had a little mind which said, I do not know when I'm going to get gas next time. So Aisha just put in a 13 gallon or liters, whatever term we go, fill the tank. I need to store more. Right. So then the car maybe internally develops these tools that take the gas, turn it into small granules, stuff it in the glove compartment, put it under the hood, put it in the cushioning of the seat that they become swollen, and then we keep driving. We see there's a gas station, and the car says, oh, there's a gas station. Let's fill it up again. Because we don't know when we are going to get a gas can. Right? So this car then starts to expand and starts to store all this gas in there. and the gas eventually, the car starts to struggle. There's more gas there, and then it gets under the hood and breaks the engine, gets into the seat, and seat expands. Your liver gets explodes. So those things start happening, right? So now bring it back to the hunter gatherer human being, right? So now taking this gas analogy, when we consume energy, and I'm talking about, energies in the calorie value, not spiritual energy. So when we ingest calories or energy, our body has a way to store it. Our brain has a way to tell us, get more of it. You don't know when you're going to get it again. So when we get more calories in, our body has this innate mechanisms to store it in different locations around your heart, in your belly, in your liver, in your muscles, right? And then it starts to, hey, can I also use it effectively? That can I get away by using less energy to do more? So we adapt. These are all survival mechanisms. And just like that car on the road, which is now stuffed up and struggling along, we become that vehicle, right? So body is very well designed to get anything in, any chemical, any food, any energy. And there are hundreds and thousands of hormones that have different pathways and processes. We don't need to go into all detail. Just understanding it conceptually will help you deal with this health issue. So they go in, and the processes energize, take carbohydrates, do this, take protein and do this to that, fat, do this. If you have extra calories going in, it will be stored somewhere. So it could be your liver, it could be your heart, it could be your, every organ around it we get. And, South Asia, visceral fat around all the organs. That's how we store it and then create a metabolic, havoc in our body, right? So the dysregulation part or lack of regulation, usually we get it in, consume it, use it, steady state, keep moving. Now, if our hormonal balances start going off with aging, women around menopause, or inactivity, stresses, all these things that we have in modern world, now this energy is not being used the way we were supposed to use it. And all these different hormones start to come into the play. Okay. Remember that car that wanted to go every gas station and get some, right? So now our body has this constant chatter noise to get food, right? You're walking through your kitchen counter. There's a bowl of, some snacks lying there. Say, hey, let's get one. So that constant food, I need to eat. Culturally, we are ingrained. Mom's telling us, hey, did you eat? Did you eat? Did you eat? Did you eat? Feed, right? So this whole chatter has been wired into our brain. So this, now let's break that down, right? So you got 5 different things in regulating energy with food. So your brain tells you, I am hungry. You eat. Your stomach tells you, I am full, stop. Right? Your body says, I got enough glucose, stop. But you keep eating, and then more glucose goes in. It has to send more insulin to bring the glucose level down. If there's more energy, let's store it as fat globules in the liver. Let's go out, work out, and burn it through your muscles. So we're trying to do all these things, but now see how it will break down. So there's a hormone called ghrelin, which is a hunger hormone. That's the only hormone that drives you hungry. It has cyclical peak. That's why we eat different times. We get hungry at breakfast or lunch or dinner. That's how it got in a time of Netflix, 10 p.m. there's another peak. So it asks us to eat. Then it goes into our stomach. There are many hormones in the upper small intestine area and stomach and pancreas. GLP-1 is one of them. GIP is another one. There are many of these hormones there. Their function is to slow down the emptying of the stomach. And so that creates a sensation of fullness. So the fullness signal goes to your brain, says stop. But if this signal breaks down, you will not stop. So then there are a lot of mechanisms defined that we overeat, we will keep eating. So all these signals, when they start to break down, which used to be regulated, are now dysregulated. So we are going through a condition of energy imbalance that is driving the health and disease states. I think that's how I think I'll try to put it together. I hope I'm clear on this.
Yes, yes, this was wonderful. And I'm glad that you gave the example of a car and fueling it up because right now gas is a premium commodity. So
Humanity,
yeah,
yeah, yeah,
yeah,
exactly.
yeah. But that's not how we necessarily view food. And I think this was perfect example that hedonic snacking. A lot of my patients come to me with that complaint that, oh, we are just constantly hungry, right? And you're right. Like today's modern lifestyle, it plays a huge role in that, right? Sedentary jobs, chronic stress, poor sleep, all of those, all of these components, because we are not really optimizing our life for health in that way, um, they are wreaking a havoc on our hormones, including cortisol, which also drives
Yeah.
up hunger. And then ghrelin, you talked about. Um, and I want to bring up leptin as well, which is like your satiety hormone, right? Just sending the signals to your brain, hey, I've had enough. I've had enough. Um, so yeah, that was great. And then I'm glad you brought up GLP-1, that is actually a hormone that is regulating your satiety as well, like how full you are, keeping you full there. So that's how it works. And it's a natural hormone that is produced in our bodies as well. So yeah, that is great. I do want to touch upon something that you just mentioned. It's like a follow-up question. So this was great. Very simplified view of what metabolic dysfunction or dysregulation is for us. How is it diagnosed? What are the key biomarkers we are looking at for metabolic dysfunction, for diagnosing metabolic dysfunction?
Yes. So, metabolic syndrome, as we used to actually call it, is, the different components. Your cholesterol could go up, your sugar levels could go up, you could have a higher blood pressure, you could gain more fat or adipose tissue inside your body, around your waist, everywhere. So all these things together, you start seeing a phenotype that you start developing disease. And it's these are very hard endpoints that can be measured. And in your doctor's visits or even self-assessment, you can start assessing that, hey, my hemoglobin A1C is going up. A lot of people have wearable data these days. My blood pressure is going up, or my waist is expanding. And these are very good biomarkers. I mean, waist circumference or your body weight or body fat percent. There are multiple things that tell you that the energy dysregulation and metabolic dysregulation is setting in. And it takes time, and we just need to be aware.
Great. So yeah, on a regular blood test, you'll see like the lipid panel, right? If the LDLs are high, above 160, right? LDL,
Yes.
if I'm
And
not
then,
wrong.
yeah, and
Yeah,
evolving.
A1,
Yeah.
say that again, please.
And the guidelines are evolving.
They are still evolving. Oh, that's a
Yeah.
good thing. Yes,
Yeah.
yes. We are always, looking at how we can make sure that we bring or give optimized premium care to our patients. So that's a great point that you made. And then A1C is for prediabetes. I think it's between 5.8 and 6.4, and then 6.4 and higher is diabetes. So
Yeah.
those are the two key ones. Like easy to look at. You can just go get your blood drawn or blood work done, and you'll see that. But then visceral fat is another one that if you have access to DEXA scan, that would help you with that too. So thanks for mentioning
Yeah.
those. Okay,
And
so
importantly, for say South Asians, there was a recent paper actually that for South Asian people, the hemoglobin A1C cutoff for prediabetes or diabetes might be lower. So
okay,
what we
tell me
know
more.
in our Western population, those cutoffs might not really apply to some other ethnic subculture patients. So that needs to be aware. And fasting glucose is actually a good marker too. So sometimes if you're that's running high. So these are all measurable things in right context, and catching them early, because this is all preventable.
Yeah.
Downstream complications from all these metabolic dysfunction elements are all causing health issues down the road, all preventable if we intervene at the right time.
Got it. Yes. Yes. I want to bring this conversation back to obesity. So I know that it's still stigmatized, right? We both are OMA members, and this is something we learn about at every conference, which I agree. And a lot of my patients, too, when they come to me, you know what? I'm lazy. They actually they're talking about themselves. I'm lazy. I can't do this. I can't lose weight. And I know that that's kind of like a mindset that's been given to them from their friends, from their peer group. So, what do you say? Is obesity a failure of willpower?
Of course not. I mean, that has been the rhetoric for all these years when we didn't have a way to treat it, and the providers themselves didn't know what to do. And I will say that growing up and in my athletic years, I just thought, oh, it's all calories in and calories out. Becoming certified in obesity medicine, learning the science, it's a complex disease, right? Just think of it this way. If you write a prescription for a pill and give it to the patient, and even half of them may not be taking it at 1 year. You write a prescription for exercise, how many people would be doing it at end of 1 year if you didn't follow through? Now, is it they're not doing it because they don't want to? Or is it that we are biologically wired to fail on these fronts? It's a much more complex disease. And I think it's really time to start calling it disease, because it is a much more, we talked about all these hormones. There's imbalances in multiple places. Perimenopausal women developing fat around their waist, you tell me how that's a failure of willpower. They're all driven to do things about it. But cortisol, other hormones, lack of estrogen, progesterone, I mean, these things all come as a biologic mechanism to create these problems, right? Different, like I know that Indians are shown to have some leptin deficiency or adiponectin deficiency. So there are things in our DNA that are making us go this route, right? So I think saying that it's a willpower issue is maybe it's a bigger problem from our provider part that we have imposed upon society, that because we don't want to recognize it, because we didn't have anything to do with it. And
Yeah.
and then we create this stigma in society, which is people get judged by their appearances, that we become important to the extent that our patients are feeling the way you said, oh, I'm lazy. We're not lazy. We are wired to be like this, right? That's how the whole world is like that, right? Even patients who lose weight on medications, they feel guilty
Yes. Yes.
that
I have
we are
had the same
cheating,
experience. Yes.
right? Other people judge them for losing weight, that they're cheating. So this is a societal stigma that has been, laid upon us, and not necessarily anyone's fault. It's a system issue, as we call. And I think, Aisha, if we do nothing but just one thing, that start increasing awareness for this, that it's
Absolutely.
not your fault, it's not a problem, it's a disease. Do we tell anybody that, hey, you have high blood pressure, just go walk it away, just lose it?
No.
Do we tell people with diabetes, hey, throw away your insulin, you don't need it, just be, lifestyle focused, will all be fine? No, right? So I think that aspect we need to emphasize more and more and more. And I think it has taken us time even in the US to get there or getting there. It's still a hugely
Yeah.
stigmatized disease. Go to different cultures, it's going to be even different. Like I actually wrote about this in India with the semaglutide going generic. There are ads in the newspapers for pre-bridal packages, 3 months of semaglutide before getting married. I mean, that's and then stop and then start and gain fat. I mean, create another metabolic disaster. So, but that's how societies work, and that's how we human beings work. That's how we judge people. But carefully, crafting messaging every time we talk to our patients that, hey, it's just not about your lack of willpower, and it's just not about your weight. It's about your health.
Yes. Yes. And that's what we are going to kind of like dive into next. And I really appreciate that you highlighted how it's been stigmatized because we didn't have anything to offer, right?
Yeah.
We didn't know much ourselves as practitioners. There wasn't enough data out there, not enough research, didn't have a medication, but things have changed, right?
Yeah.
So, yeah, I mean, the more discussions we have on this topic, the more awareness we bring to obesity, the disease of obesity, and how it can be treated, how we can help our patients is going to change that game. And you're absolutely right. Yes, in South Asian culture, it's even more stigmatized than,
Yeah.
yeah, other cultures. So, yeah, I mean, we do have to recognize that our lifestyle has changed dramatically from that hunter-gatherer lifestyle. If we were following, and I do know that there are a very, very, like, I think there are 7 tribes left who are still following the hunter-gatherer lifestyle in the all over the globe. They don't have that issue because they're still like very active. Like the food is scarce. Like they're still hunting, going out hunting, storing it, eating it just based on their caloric need or energy that they need from food. And but we don't live in that environment anymore.
Yeah.
We don't. So obesity is a disease and it is very complex. And now that we have help through medications, it's a good idea to address it because it's a huge cost on our healthcare system. Yeah. So let's talk about new medications. Medications actually. First, I want to address the medications that we have been using for a few years now. So how do medications like Wegovy or Zepbound, how do they help us improve metabolic function? And it's, because a lot of the patients are like, oh, it's all about suppressing appetite. I can skip meals. Yeah. So why a GLP-1 medication can actually help the patient rather than skipping meals?
Yeah. So, I mean, that we know that lifestyle measures also work. Nutrition, exercise, everything, and that should be the foundation of our building good health with weight loss. And on top of that foundation, the magnitude of benefit that we get with lifestyle is finite. Maybe 5%, 6%, 7% weight loss that we get with that. We create more healthy habits, and that will help us in the long run to sustain your weight loss that you get from medications. Right? So that's your baseline. So then you have these medications that are GLP-1 or GLP plus GIP agonists, or they function like that. They do multiple things. Okay, so from these gut hormones, they can tell your brain to stop hunger. So there's blood centers in your brain which make you hungry, so they can suppress that. They can also suppress what we call food noise, and we can talk more about that later. It can also slow down the motility of the gut. So a stomach is like a bag. When we put food into it, so food comes into it, and the stomach has a little opening through which the food then goes out into small intestine. So stomach churns everything, makes it squishy, little soup that then will go forward. If the stomach is full or distended, that's when we get a signal to the brain that I have enough food in there. And the top of the stomach is where the ghrelin comes in, actually. So the more it gets stretched out, the more signal ghrelin goes down. So you get a signal that I'm full, right? So, and leptin comes in also. So if you can slow down the emptying of the stomach, then you're sending the food, the signal to the brain earlier. So those two major mechanisms then suppress hunger, decrease food noise, get your gastric emptying corrected, makes you full and satiated, and so your caloric intake is what you need at that point. So that's the primary mechanism it does, and then it works on many other receptors in the body. That's why you get benefit in all different aspects. You start losing weight, or you start losing fat mass and some muscle mass, and then you start seeing changes that your blood pressure goes down. Your risk for heart disease could go down. Your diabetes gets under better control. Most of these medications were for diabetes to begin with. Your sugar control goes down. And enough data coming out that, even addiction, food is addicting. So addiction to alcohol or other drugs, that could go down. Autoimmune things can improve. Psoriasis, skin disease, given along with one of these medications, has better improvement. So we have, everywhere, that your sleep apnea, that, you stop breathing while sleeping, which has tremendous cardiovascular issues, that gets better. So this is the most overarching problem, that if you address, all the downstream diseases that come from that are getting better, and we have evidence for that, and then medications are getting approved on all these indications.
Yes, I agree. I agree that all these biomarkers that we're looking at, especially you mentioned obstructive sleep apnea, which is a big risk factor for cardiometabolic disease, and that goes down. Primarily, I do, just as you said, that these drugs were actually meant for diabetic patients. So primarily it starts working at cell level with the insulin sensitivity of your cells, right? So that improves. Once that improves, then all the other things start lining up too. So that's great. Awesome. Who is a candidate for these drugs?
So, we measure, I think I'll give you the first answer, then we'll delve deeper a little bit on this, right?
Sure.
So who let's flip. I'll ask you a question. Who should strive to gain optimal weight?
Oh, that's a good question.
Right? Anyone who's at risk of developing disease from it.
Yeah, exactly.
Right? So, so that should be our goal. That our goal is to improve people's health.
Yeah.
Right? And so, but to improve people's health, we have to come up with, structure. And to come up with structure, then we have guidelines. So the FDA will then say, hey, this medication is approved for this reason and this reason. And that's how you use it. So both the medications that we have on the market for reducing weight are for people who have a BMI above 30. Okay. Or a BMI above 27 with comorbidities. What we mean by that is that elements of metabolic syndrome, high cholesterol, pre-diabetes, sleep apnea, or fatty liver disease, any of the problems that come along with your weight, if you have those and your BMI is 27, then that's an indication. So these are the two indications that's approved for, but there's a lot more debate in scientific world on what is the risky weight? What is the weight that causes risks to your health? And is it really just the weight that causes that? Or is it your body fat percent? Or is it how your waist circumference? Or is it your ratio of your height to your waist? Like in Hispanic culture, a lot of South Asian cultures, we are shorter but broader. Is that, even if it was in the same BMI, is it good? You may have seen a lot of people who are leaner. Their legs and limbs look okay, but they have just central obesity.
Yeah,
So
visceral fat. Yeah.
So I think, yes, we have those two major indications, and broadly we all fit into that. But this conversation will keep expanding in terms of that. We should be treating people who are at risk of disease. If I'm going to develop diabetes because of my central obesity, and even if I'm not uh, certainly meeting certain criteria, like for these numbers for South Asians are lower. For example, the
Yeah.
studies from China are, BMI of 23 is being overweight compared to BMI of 27. So all these nuances, I think now is the time that they'll start fitting into these equations. So it's a great start, right? But we should be thinking in terms of disease, not just these absolute numbers.
I like that, Dr. Rajwanshi, how you're explaining like it's not black and white. So
Yes.
those are the two criterias that are approved or more practiced at this time, but
Yes.
it's not as black and white as we would like to think. There is gray in between, and those are those gray areas that you're mentioning. Visceral fat, right? Somebody who has high visceral fat, or as you said, the ratio of height to weight, right? Well, and I know I have seen a lot of patients who look lean, especially women who do a lot of cardio.
Yeah.
They look lean, but they're not really. Their fat percentage is pretty high.
Yeah.
So you put them under DEXA, and then you look at their scan results. You're like, oh, I never expected that. Like, what is this, right? Because they have sarcopenic
Yeah.
obesity.
Totally.
So
Exactly.
yeah, so yeah, those are also a lot of things that we do need to look at. So do do those patients need help, or can we help them? Absolutely, right?
Absolutely. Yeah. And that's why I think not only spreading these messages across into populations, uh, making providers more aware. We make fine-tune adjustments into any disease treatment, whether it's your diabetes or your high blood pressure. Hey, let's adjust this dose. Let's start now. Let's do this. Let's fix salt intake. So we do all these things for other things. And the moment we start thinking of obesity as a disease,
Yeah.
then we'll start doing all this. And that's where the nuance with your provider relationship is.
Yeah. Yeah, absolutely. Absolutely. Okay, so this next question that I have for you, I am super excited to discuss this. I know that the weight loss drug landscape is shifting. And now we are moving towards, and I think you kind of like touched upon it, we're moving towards daily oral pills. So that kind of like, I think it reduces obstacles to taking GLP-1 medication, because a lot of people don't want to inject themselves, or the accessibility wasn't as good. But with pills, like everybody knows, like that's how medications are taken. Most medications are
Yes.
like
Yeah.
taken through oral route. So let's talk about these triple agonists. Some of which are one of which is actually still an injection, and the oral medication Foundayo. Tell me more about it. What are these medications, and how are they now gonna elevate the obesity care?
Yeah. Totally. I mean, so if you look at the early landscape of these medications, so GLP-1 agonist, there was a medication that could only be given, that could only work if given daily. right? So the problems during in last 20 years have been to how to make that these medications be given less frequently and function equally well. So chemically, how do we make them that way? And how do we even convert them into an form that it can be taken orally and still be it's a peptide, so it will be
Yeah.
still be effective in functioning, get absorbed and function like an injectable medication. So those are all the technical advances that has led to this. So from daily, we created these medications which can be given weekly injections, and those are the two major the injections that are available. So you have semaglutide, which goes by name of Wegovy, and given once a week, okay, which is a GLP-1 agonist. So once on one hormone has a certain percent weight loss. And I would like to caution people to attach too much to the percent weight loss outcome. A 15% versus 17%, both are meaningful for your health.
Got it.
Our goal is to not cut down as much weight we need to or indiscriminately. Our goal
Yeah.
is to create numbers that make you healthy. It's a disease. We need to not bring your blood pressure down to 40 over
Yeah.
20
Yeah.
when we treat your
No.
blood pressure. We
Not
bring
at
it down to
all.
a normal range that your
Yeah.
damage to other organs is minimized. Similarly, here, without getting attached too much to the bigger numbers, um, meaningful weight loss will help us get better health outcomes, right? So you got Wegovy, uh, which is semaglutide. Then you have another medication that's called Zepbound. So Zepbound is tirzepatide, which is GLP-1 and GIP. It is a higher percent weight loss. That's why it's very much more popular than Wegovy these days. But both are excellent medications. Okay. Now both these medications are now available in oral form. So you have an oral Wegovy pill, which is given daily, and then you have an oral Foundayo pill, which is a different uh, compound called orforglipron. So you got semaglutide tablets, you got orforglipron. So these are now two oral pills. So, and this is the current approved status. And then there's even now data on higher dose of semaglutide giving up to 27 28% weight loss. So these things are evolving. So these are two major approved categories. Now, route of administration, whether take injectable or take oral, could be actually a very personal choice. It's very interesting. A lot of people prefer taking once a week injection and be done with it, right? But for countries where uh, maintaining the injectable medications or a chain of safety, oral pills will be a great boon because they're in a wrapper, stable at room temperature, and can be left outside or travel long distances. So all those problems would be solved, and it's easier to take. Right now, between those two medications, the Wegovy pill and the Foundayo, there with Wegovy there are some restrictions on how you take it, what time in the morning, fasting, and this much time. Foundayo can be taken anytime. So all these minutiae is there, but both these pills are actually quite good. So again, if you don't attach too much to the percent weight loss, all these medications create meaningful uh, weight loss for your health.
Great.
So
Awesome.
whatever is your preferable route to go for it, you go that route. And there are also multiple other things will come into the play. You have been on an injectable for a year or 2 years. Now you have lost the weight that you wanted. Now you want to maintain it. So now can I switch to an oral version of it, right? Which
Yeah.
is also shown that yes, that works, right? So
Okay.
so they're giving us more options to treat this disease on a long-term basis. And I just want to caution everybody that stopping the medication, it has been shown that the weight tends to come back.
Yeah.
Right? So
Yeah.
so you're treating this long term, uh, maybe indefinite until we have more data and maybe newer drugs.
Yeah.
Uh, so these combinations will keep evolving. That you can stop the injectable, get on the oral pill, and then that's an easier way going forward. Or if you prefer once a week injection, that's fine too. And then, as you mentioned, you meant, I think, retatrutide with the triple agonist, when
Yes, retatrutide. Yeah.
GLP-1, GIP, and
It's still in
glucagon.
trials, right? Is
It's
it
still right. It's
still
not
in trials?
FDA approved, but there's
Okay.
many other. So there are at least 10 to 20 other drugs in the pipeline. Okay. So, and then how are they all different? So they have either some of them are just GLP-1, some have say glucagon, some have amylin, some have other. So all these variations are coming down the pipe, which are equally effective or more effective, right? Then there are some coming down the pipe that the frequency is going to go even higher. So what if you take once a month? Right?
Yeah.
So if you get an injectable medication that you can only take once a month, that might be a different ballgame.
Yeah,
In
I think
trials, will
patients would
likely
like
get approved,
that.
right?
Yeah.
In trial and will likely get approved.
Nice.
So,
Very nice.
so all these developments are coming down the path. So I think if
Yeah.
you have the mindset that, yes, I'm going to do something for my health, I'm going to reduce my uh, adipose tissue or sick adipose disease by dealing with my body fat, and I am successful on that route, I have so much hope that it'll only get better.
Yeah, no, I love this. Especially like I know when we're trying to put patients on a maintenance dose, they were still injecting like a microdose, right? And I think that if they can go on pills, a lot of patients would like that if they are maintaining
True.
now.
Totally.
With the once monthly, I'm just curious
Yes.
what your take is on this because I'm kind of like thinking out loud over here with you. Um, there's a half-life or a shelf life, right? Half-life of the medication when you inject it. So like it's really high when you inject it, right, in your bloodstream, and then it starts tapering down. Uh, Once a month, I'm a little surprised like that would work.
Yeah, and yeah, it's working. The good results in
Yeah.
trials. It'll likely get FDA approved
Okay.
for that. But
Yeah.
again, coming back to the same question, whether we are assuming that take pill is better than injection in terms of people
Half-life.
adhering to it. No,
Oh
no,
yeah. Oh yeah. 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 If they are
right?
taking it daily.
If they're
Yeah.
continuing to take it, right? So
Yeah.
that's a that might be a very personal preference. And if you take an injectable that's once a month, and if you're the someone who gets a lot of side effects with it to start with, now do you linger on for a month suffering, or you can stop in a week? So if you were taking the injectable once a week, so these are all questions get answered in your patient provider visits and all that. That's why that's why I also worry for the uh, that we are not building comprehensive care packages for patients everywhere in the world to go
Mhm.
with these medications. We are very easily dispensing them
That
without
is so
building all
true.
the things around it, right? Because there's so many nuances to it. It's very personal, knowing your patients. So those care programs should be built, and full, lifestyle counseling, nutrition counseling, physical, encouraging physical activity, and that's why my personal interest comes in, right? That how do you enable people to do all this together,
Yes. Yes. It's
right?
not
I mean,
just being on medication. The goal is to have our patients become a healthier version of themselves, and that also includes having high energy levels, right?
yes,
As soon as you have more insulin sensitivity and all the other things that come along with it down the pipeline, all the health biomarkers that we just touched upon, um, I have seen my patients tell me like, I feel so much better. Like, I can actually now move. I couldn't even when you recommended that I should go for a 15-minute walk every evening, I couldn't bring myself to do it. I didn't have that energy. Now I can do it,
yeah.
right? So yeah, moving your body. So all those lifestyle interventions,
Well,
we want our patients to take up those lifestyle interventions so that they can be healthier, better versions of themselves for the rest of their lives. That's the
exactly.
goal.
Yeah, and And I think one critical thing also is that that patient has a relationship with you, right? So you are, so even if, I'm a big, technology buff and fan, even if you have all layered technology to nudge them in between the visits, you're still the curator.
Yes, as the
They,
practitioner, you are the human, right? They trust you.
right? So you are enabling all those other tools, but they're coming to you. So, and you will also motivate them in a way that, hey, look, we look at your muscle loss. Most people don't lose this much muscle. You're losing more. Can we include a little bit more movement? Can we just, little 5 pound lifts and, chair poses, anything that we feel that will work for
That
that
patient can do.
individual,
Yes.
right?
Yes. Yes.
Let's,
Yes.
let's not run that car on a bullet nutrition, meaning ultra processed food, rather than fill a gas. I put just one bullet and that works, makes my car work. No, that our shelves are full of ultra processed foods, calorie dense foods. Don't reach out for that. So though all those counts of counseling things that come with it are coming through you, right?
Yes, 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 absolutely. Yeah. And I just love it how all these different medications that we just talked about too, they allow us to customize the care for a particular patient. I have seen patients who do really well on once a week injections, and then I have seen them who are like really struggling on them.
Yes.
So
Yeah.
now that we have oral route, now that we will probably hopefully have that once a month route. Some patients might do really well on once a month, right? They would have minimal to not no side effects, but then some might not. So it gives us this ability to be very flexible and create these um, customized prescriptions for our patients, which we didn't have the ability to do. And same thing, just like you just mentioned, along with that, then goes those lifestyle interventions, right? I try to customize those for my patients too, right? The nutrition prescription, the exercise prescription. Are you losing a lot of muscle mass? Are you not prioritizing protein intake? Because we don't want that patient to end up with sarcopenia. Now they have lost all the weight, but now they have another problem on hand, and
Exactly.
we want to avoid it at all costs, right?
Yeah. I,
Because it's not that you can't gain muscle, but a lot of people, when they're at the point in their life when they're going on these medications, it's a little bit harder to gain muscle mass. So if you have good muscle mass, we don't want you to lose it. We want you to preserve it as much as possible. So yeah, that's a great. Okay, Dr. Rajvanshi, this is a question that I have for you, and I know we talked like a little bit of it already, but what is your hope for the future of weight loss and metabolic care?
so I do have a prediction.
Okay.
Even so, when you look back, you know, at history of human health, mm, 20, 30 years from now, you'll say that these 4 or 5 years of time frame changed human health because all of us now have option of gaining healthful outcomes from these medications. So lot more of us will be healthier. So human health will be big time impacted by these medications. And if you look at our historical evolution, right, uh, we as a human race, we tend to die, and we die from different diseases at different times. So we did antibiotics for infectious disease when we were hunting in the forest, and or in the wars we were dying of infections. So that was one wave. Similarly, you have insulin. Many other things have happened in evolution of human health. This will be also one big thing that there'll be tremendous health benefit that you'll see downstream. We have seen data on heart disease going down. We have seen data on kidney issues going down. We had one trial on cognitive function, Alzheimer's. It didn't pan out completely, but maybe some hope in the future, right? We have seen autoimmune conditions getting better. We have seen addiction improving. We have seen sleep apnea improving. We don't even know how it affects our gut microbiome. Maybe it's some change happening there. So lot more will come down the pipe that will have good outcomes. So we'll live healthier things. So I think it'll be a major turning point in our human health. And yes, of course, AI somehow is going to play a role into it. But so our health
Yeah.
is right.
Yeah.
So
Yes.
my hope for the future is that we'll have better agents, better medications, better ways to have people comply with taking them. We are, as human beings, we don't do things that we're supposed to do, right? That's our wiring, our nature. Even if something's working, even cholesterol pills after a heart attack, have the patients discontinue up to 1 year. So we'll all things that will make us better do that. Things that will bring our lifestyle measures to the forefront in a way that it is accessible to everybody. It is available. It's somehow easier that people get into that. Stress management, education, advances in sleep technologies, all these other things that play a role will all come together. And so that's my hope of the for the future, that these metabolic disease fight, we will win this, and all the elements of that metabolic disease that are important will be addressed.
Yes, absolutely. Absolutely. We are looking at some seismic shifts here in the next few years. And my hope is also that we will be able to extend our health span and lifespan tremendously. Um, a lot of times, and I've been kind of like counseling my patients on this, that obesity care is anti aging care, honestly. You take
Yeah,
care of obesity with GLP-1 medications, you are looking at a far lower rate of cardiovascular disease risk. A lot of those biomarkers are already getting taken care of, and that's what it is. Then you can adhere to lifestyle interventions better. You can increase your muscle mass. You can you don't have to worry as much about the food noise all the time. So a lot of those obstacles that we look at in this modern lifestyle, we're like kind of like addressing those right away for you with this obesity care uh, framework that we have now. So yeah, that would lead to much better outcomes
exactly.
for patients'
And
health.
and I think that this might be the best longevity approach.
Yes,
You know,
obesity care is longevity.
yeah,
Yes, yes. Because I think a lot of times we are not understanding that at the root cause of a lot of these diseases that we are looking at that are preventing us from, living a healthy long life or a functional long life is what? Obesity, right?
yeah.
Yeah. So yeah, I'm really, really hopeful. I'm actually very excited about all the things that are coming down the pipeline. And I want to have you back for AI. We are going to like nerd out on AI technology and how
Totally,
we can implement it
totally. Yeah,
better for our patients. And even in healthcare system, we have to do that one of the days.
yeah.
So Dr. Rajwanshi, where can people find you and learn more about your work?
I think I write on LinkedIn, so that's the place. And
Okay.
we are in process of developing an AI native metabolic center. So once that gets launched, you'll hear about it. You'll find ways to find it.
Awesome. Oh, I love that. I can't wait.
Uh-huh.
But yeah, thank you. Thank you so much for taking a deep dive into obesity care, into metabolic dysfunction, what is down the line as far as medications are concerned, and what we are looking at. I think this is a topic that I kept on coming back to. Like, I got so many questions from my patients, and you have addressed all of them, if not most. Yeah. So this was really, really helpful. I know that our listeners and viewers like really enjoyed it. I just see, I'm looking at like one of the comments here from Brian, that great work here, Aisha. Thank you, Brian. Thanks for listening and watching to us. And thank you for listening to us or watching this video if you're doing it offline. Or if you're watching a recording, I wanted to say. This interview is going to go out in a podcast format on 9 to 5 Wellness Podcast on Sunday, this coming Sunday. I'm totally like messed up with my dates right now. So whatever that date ends up being, let me just pull it up right away. Yep. So that would be 17th, May 17th, it would go out. And if you consume content in a podcast audio format on your way to work, driving on your way to work, you will be able to listen to that on Sunday. So thank you so much, Dr. Rajvanshi, for
Thank you. Thank you
coming
for having me.
here and spending your time with us and explaining all of this to us and helping us understand the disease of obesity better. Thank you.
Thank you. Thanks.
Thank you so much. Okay, everyone, bye. I'll see you guys soon.